Hi, I'm Dr. Felice Gersh, your integrative OBGYN physician. This time around, we're going to talk about testosterone and peri and menopausal women. So it's very trendy now. I'm finding doctors of all types of training that take care of women producing prescriptions that prescribe, of course, testosterone. But just for no obvious reason other than a woman is perimenopausal or menopausal. What is the reason? Like, is testosterone a hormone that changes at menopause? What's going on here? And if you need testosterone, what are you accomplishing when you get it? And how would you know if you need it? How would you know how to dose it? And how would you know how to get it? So there's a lot of questions that surround testosterone. Well, the first thing is to understand a little bit about this really important hormone. It's present in women. It's not a male hormone. It is a hormone, but it's present in much smaller amounts in women, maybe a tenth or less the amount that a man would have. Well, where does it come from? What organs produce testosterone? Well, in terms of circulating testosterone, because there can be testosterone produced in organs where it doesn't go anywhere except stay in that organ. For example, in the brain has the ability to make testosterone. But in terms of circulating testosterone, it comes from the adrenal gland and the ovary. And we're talking about women here, of course. Now, how much comes from where? Well, from the ovary, about 25% of all the circulating testosterone is ovarian derived. 25% comes directly from the adrenal gland. What about the other 50%? It comes predominantly, about 80%, from adrenal produced androgens like DHEAS and DHEA that are converted peripherally, primarily but not exclusively, in adipose, aka fat tissue, into testosterone. So close to, not completely, but close to 75% of all circulating testosterone is adrenal derived. Now, what happens as you age to the production of testosterone from the adrenal or from the ovary? Well, it turns out that the area of the adrenal gland that produces androgens, which would be all the androgens, including testosterone, is called the zona reticularis. Now, if you do imaging as a person ages, you will find that the zona reticularis in general starts to shrink in size. And consequently, the amount of androgens goes down. But it doesn't go down at a particular rate in any particular person that you can predict. So it's a general trend. In general, as you age, everything kind of shrivels up, including the zona reticularis. The ovary can produce testosterone for the duration of a woman's life, well past the age of menopause, but it too can diminish over time. So it's not unusual for a woman to benefit from androgen supplementation, whether DHEA and or testosterone with advancing age, but not always and not necessarily at the menopause. So what happens to testosterone production from the adrenal gland at menopause? Well, if anything, it might actually go up. Now, how could that be? Why would it go up? Because when you go into the transition into menopause, you end up in a more stressed state. And that is because the autonomic nervous system is composed of two arms, the parasympathetic, which is the calm state controlled by the vagus nerve, where you would be, they sometimes call it rest and digest, where it's like the baseline, where everything is working just perfectly and calmly. But there's the alternative part of the autonomic nervous system, the sympathetic, and think of S as stress. That's what it's about. And that requires a particular neurotransmitter, which is norepinephrine, and the vagus nerve, which controls the autonomic nervous system, the component that's called the parasympathetic, has a neurotransmitter, predominantly acetylcholine. Well, you need acetylcholine, of course, for the vagus nerve to produce all of its wonderful calming effects. And in order for acetylcholine to be properly functional and produced, you need adequate amounts of estradiol, which of course are not going to be present in the normal woman as she's going through menopause because she's not going to have adequate estradiol produced. So there's a trend towards sympathetic dominance, stress dominance. Part of the stress response is adrenergic, as in adrenal. So the adrenal gland starts putting out more cortisol. Well, the hormone that comes from the brain that triggers the production of cortisol is corticotropin hormone, ACTH. Well, it turns out that that same hormone not only triggers the production of cortisol, but also the androgen, DHEAS. So when you're under stress, you will produce more cortisol and you'll produce more DHEAS. And from DHEAS comes testosterone. That's why when women are under stress, they sometimes will get outbreaks of pimples, okay? Because you get too much testosterone, too much androgen. And cortisol doesn't help either. So when you're transitioning into menopause, you may actually have an increase in the production of androgens. And also the ovary may produce more testosterone. Now, why would that be? Because the trigger to producing testosterone comes from initially the brain to the pituitary gland. And then the pituitary gland makes its triggering hormone called LH, luteinizing hormone. And that will produce in the ovary, cause the production of testosterone. Now, why is that? Because testosterone is the precursor to all estradiol, the estrogen made by the ovary. So what happens as you transition into menopause? And then, thereafter, but especially during the menopausal transition, the brain has sensors, but it doesn't have sensors to testosterone. It will never downregulate the production of testosterone based on levels. It has no sensors to it. There's no what we call a feedback loop. So no matter how high the testosterone goes, the brain won't shut it down. But estrogen, totally different story. The brain has sensors to estrogen. And when the ovaries aren't making enough, the brain perceives that in its sensors and says, oh, we need more estrogen. So it puts out the signal to the pituitary gland, which then puts out its hormone, which is LH, luteinizing hormone, that goes in the bloodstream to the ovary. And that triggers the ovary to make testosterone because all estradiol comes from testosterone. But you're not going to make as much estradiol because you don't have as many functional eggs. Yes, in order to make estradiol, you need to have functioning eggs. Well, that declines both the function and the number as we age and enter into perimenopause and menopause. So the brain just doesn't like that. So it wants to have more estrogen because it loves estrogen. So it keeps putting out more LH and more testosterone is then produced by the ovary, but less and less estradiol is produced. Initially, you may have a surge, but then it goes down, then another surge, but then it goes down. And eventually, it's just down. But the LH keeps coming out. So testosterone is still being produced. And there can be a significant increase in the amount of testosterone produced during the perimenopause years. And when you have less and less estrogen, you have less and less sex hormone binding globulin. That's a binding protein that binds testosterone. It's made in the liver. And when you have less sex hormone binding globulin, you have more unbound testosterone. And the only testosterone that can act on the tissues anywhere is the unbound type. Because if it's bound up to this molecule that is a binding protein, it will not release the testosterone to actually do anything. It's like imprisoned by sex hormone binding globulin. And 99% of all testosterone circulating in the blood is bound up, mostly by sex hormone binding globulin, which holds on really tight, and some to albumin, which is less tightly binding. So less estrogen, then you're going to have a change in the sex hormone binding globulin. It will go down. When you have less sex hormone binding globulin, because you have less estrogen, you're going to have more unbound or available, bioavailable testosterone to act on the tissues. Because it doesn't matter how much you have, it matters how much is available to the tissues, the unbound fraction of testosterone. So as you transition into menopause and thereafter, you have more and more unbound because you have less and less sex hormone binding globulin. And if you've ever been to a nursing home or been around elderly women, you see that many of those elderly women have very fine hair. Like you can see a lot of their scalps, little bitty wispy hairs, and they have whiskers coming out. They're not on testosterone. They just don't have enough sex hormone binding globulin, and they still make testosterone and other androgens from their adrenal gland, and it's unbound, and there's no estrogen to counter it. And so they have whiskers and they have androgenic alopecia. They lose their hair. Now, no woman wants either of those things. So you have to be careful when you give testosterone because you may end up causing acne and facial hair and hair thinning in a woman who really has a significant amount of unbound testosterone, even if she's aging and she has less total testosterone produced. Because with aging, over time, there will be a trend towards less and less production of androgens. That's a general statement, but it doesn't have anything to do with menopause, except that you may have more produced around the time of perimenopause. So let's be careful about throwing testosterone at all the ladies, okay? I don't know why this started. It's just inappropriate, shall I say. Now, let's say you come in and you see your doctor and you say, you know, doc, I have no libido. I have no sex drive. What can you do for me? Should I go on testosterone? Well, the answer is maybe, okay? So there is only one condition that is actually FDA approved for the use of testosterone. Everything else is what we call off-label. Off-label is not illegal, it's just off-label. The FDA doesn't have an actual approval for that use. So what is the one condition that is approved for the use of testosterone? It's a very strange condition. It's called hypoactive sexual desire disorder. Now, that is not the same as low sex drive or low libido. It's a unique thing that is kind of concocted. And what it is the woman has, whatever the frequency of sexual activity she has, she thinks she should want more, but she doesn't want more. But she thinks she'd be happier if she did want more. So she wants a drug to make her want more, okay? So if say a woman has, I'm just making this up, she has sexual relations every other day. But she thinks she'd be happier if she actually wanted it every day. But she doesn't. So she has hypoactive sexual desire disorder. What if a woman has sexual activity once a month? But she's totally happy. She thinks once a month is just fine. I'm happy. Okay, then she doesn't have hypoactive sexual desire disorder. So that's it. That's the only approved condition that is approved for the use of testosterone. And it has nothing to do with the testosterone level in the blood. In fact, they don't even measure it. We don't really care. You just don't want to go above the upper limit of the reference range. So you're not trying to give super physiologic levels of testosterone, but it doesn't matter if you're in the bottom 10% of the reference range, the middle 50 percentile, the top 10 percentile. It doesn't matter as long as you're in the reference range. Reference range means reasonably random people who are tested, and 95% of those tested people score from the bottom number to the top number. That's your reference range. So hypoactive sexual desire disorder does not depend on the level of testosterone. And that's the only FDA-approved use. But what if you think you would benefit from testosterone and you would like some because you've heard, and this is not untrue, testosterone does have functions in the female body. It helps with bone and muscle. It helps with brain function. It probably has some degree of anti-breast cancer. So testosterone is a smaller player in terms of some of the effects that it has, but in terms of absolute amounts, it actually is a lot of testosterone when you look at all the testosterone, especially that's coming directly and indirectly from the adrenal gland. So it's not that there is a little bit of testosterone in the female body, it's just little compared to a male, okay? But what if you think that you would benefit? And you might, okay? So you would want to look at sex hormone binding globulin levels. You want to look at total testosterone, and you could look at free or unbound testosterone, but recognizing that that may not be as accurate as we would like because the numbers in females are so small compared to in males that I feel, and others as well, that it's probably more accurate to look at sex hormone binding globulin to see how high or low that number is, and then look at the total testosterone. Because there's nothing precision about this. There are actually no guidelines. Just so you know, there are no guidelines for what dose of testosterone to give, what level of testosterone in your blood you should treat, what amount of unbound or free testosterone or sex hormone binding globulin should be a warning that you need testosterone. There are no guidelines. When I say none, zero. So guess what I did? I made them up. I'm just telling you the truth. I made up my own guidelines. Sex hormone binding globulin, I always want to measure. And if it's like in the bottom 50th percentile, that means you got a lot more unbound testosterone than you would have if you had high sex hormone binding globulin. So that I keep in mind. And then I look at the total testosterone. So the total testosterone, when you look at the numbers typically, and they can vary from lab to lab, but we'll talk about the most typical. Usually the bottom number would be something like 3 or 4, and the top number would be something like 48. So it's a big reference range. We'll say because it varies from lab to lab, I'll say like 3 to 48, okay? So when would I treat if a woman said, you know what, I think I might benefit from testosterone because I have low sex drive and I feel I'm not as strong as I used to be, and I just feel kind of blah, and I don't have motivation, and I feel like a wimp, and I think I could do better with more testosterone. So I look at the level, and if you are in the single digits, now recognize I made this up, okay? There are no guidelines. There is zero official guidelines and no indications except what I told you. So if someone is in the single digits, so their total testosterone is like 3, 4, 5, 6, 7, up through 9, and you do it more than once, you test it more than one time, then I think that woman is low, and I would be more than happy to treat her if she so desires. Well, what about in the teens? Well, that's kind of iffy, but if she would like to try testosterone, I'm more than happy to give it in the teens. What about in the 20s, if she's in the 20s? Well, if it's like 20 to 25, I think that's not unreasonable if she wants to give it a try. It's not like it's going to be dangerous. I'm not going to give a high amount. I'm not going to do a transgendering procedure here. Well, what about if it's in the upper 20s, 30s, into the 40s? Well, I'm going to probably try other things and look at, of course, I'm going to also look at the DHEAS and see where that adrenal is. But, you know, there's so many causes of low sex drive. There's like just exhaustion, poor sleep, relationship challenges, nutritional problems. You know, you want to look at other things. Everything is not testosterone, okay? It's not, life isn't quite as black and white as that. And, you know, I'm not unwilling to try. As long as I'm, just like with hypoactive sexual desire disorder, you want to stay below the top of the reference range. You don't want to go above into the top beyond 97.5 percentile of people. You know, you don't necessarily want to get all your patients into the 99th percentile for testosterone. There's no data that says that's really the goal, okay? So, you know, I would consider it if somebody pushed me, but I don't think the problem is low testosterone if somebody's total testosterone and their sex hormone binding globulin is totally fine and their numbers are in the 30s or 40s or even the upper 20s. But there's nothing wrong, nothing illegal in giving a try. If somebody wants to give it a try, but you don't want to get too high. What I'm finding is a lot of women are being super dosed on testosterone. So if I said the upper reference range number, that means that they test women, remember I said, and that 95% are in that reference range. So you're going above the top number of the reference range, you're way high. You're over in the top 2 percentile approximately of all women, 2.5 percentile. And then you get above the top of the reference range, you're way above that. Well, I'm finding women being treated with testosterone, and their numbers are double, triple, even higher than that, the top number of the female, normal female reference range. This super dosing of hyperphysiologic dosing of testosterone, I don't get it. What are they trying to accomplish? What do they think is the point of giving testosterone that's way beyond anything that a normal, healthy female would ever have? I'm a simple thinker. I don't think I can do better by overdosing women. We know men who have overdosed on testosterone because they wanted to have like super muscles, the bodybuilders and doping and stuff like that. They did not fare well. They have emotional problems, cardiovascular problems. Why would we do that to a woman? Testosterone has a whole unique set of effects. Some are good, but overdosing is bad. Okay, it will change your gut microbiome composition for one thing and not for the better. So please, if you find someone wants to overdose you, that's as simple as I can say it, overdose you on testosterone, or just wants to give testosterone just because they can, I don't think that's a good reason. That doesn't make any sense, okay? Testosterone does go down with aging, but it doesn't go down at menopause. There's no mechanism that it goes down. It may go up. And some women don't ever want to be on testosterone. Women who've had polycystic ovary syndrome, women who've had to fight acne most of their lives, or they're dealing already with hirsutism or androgenic alopecia. Their hair is really fine and thinning. They may not want extra androgens in their body. And who says they have to have it, you know? So there's nothing wrong in not giving women androgens, but if the testosterone level is quite low and they have symptoms of weakness or motivation problems, or they have energy problems or libido problems, or they have that weird condition, hypoactive sexual desire disorder, no harm in trying. But what dose should you give? And how would you give it? There is not a single commercial testosterone product for women. There are testosterone products for men. And it's not a good idea, in my opinion and others, to give a male dose testosterone product for a woman. The idea that you can take a packet of gel, for example, and turn that one packet, which is designed for daily use in a man, and turn it into 10 doses for women is really remotely possible, okay? Because you get a little packet of gel and somehow you're going to turn that single day dosing of gel for a man into 10 individual identical dosing packets, you know, from little bits coming out of this gel pack. For women, it's just not going to happen. I've seen it done. Every day is a new adventure. You get a different dose every single day. Sometimes it's double the dose. Because how do you measure a teeny, teeny drop of testosterone coming out of a gel pack? Or even worse, a pump, where you just have a pump and you have to kind of figure out how to turn it into 10 separate little doses. Well, what about testosterone shots? Oh, no. Do not do testosterone shots. You're going to get a big up and then a down, and an up and a down. And the up is going to be too high. Okay, so don't do it. Testosterone, you'd have to do a teeny bit of testosterone shot like every day. Who's going to do that? Okay, so if you're not doing a teeny shot every day, even then it's going to be high in the morning, low at night, but you're going to end up having ups and downs, ups and downs. Don't do it. You can't, you're not going to get a good dosing regimen. What about pellets? I really hate pellets. When you give testosterone pellets, this is what you get, really super physiologic overdosing, and then it slowly goes down at a completely unpredictable rate until it's actually kind of too low, and then you get another super physiologic level. Please, please don't do pellets for women. Maybe for a man, but don't do testosterone pellets for women. Well, what can you do then? Well, how about compounded cream? Okay, that's the best way. You need to get a good compounding pharmacy, and then you get it put into a cream that you can dose properly whether it's with a syringe or a clicker or a ticker. And even that, it's not perfectly precise, but it's going to be a whole lot better. And start low and do measurements of the levels to make sure you're not going super physiologic. You don't want to go over the top of the reference range. So I usually start low, like 1 milligram, sometimes 1 milligram twice a day. The most that a woman usually would ever be on is about 5 milligrams a day, but occasionally women may go higher than that. The absolute most should be 10 milligrams, but it's very few women that want or need 10 milligrams of testosterone every day. So usually 1 or 2 or 3 milligrams is all a woman needs. And then you get the level measured, okay? You don't want to not monitor. You don't want to not measure because you want to know what you're giving. You want to make sure you're not overdosing. That's the main thing. And because there's no clear relationship between dose and the way a woman feels, I wish it were so precision oriented, but it isn't. Then you want to see how yourself or your patient feels on a particular level. You want to look for side effects. If you get too much, you can have virilization. Remember, you can turn a woman like into a man with too much testosterone. So you don't want to have clitoral enlargement. You certainly don't want to have facial hair and hair thinning. So you don't want any of that. You don't want acne. So you want to watch for side effects. You don't want your voice changing. You don't want to be have a man's voice. You don't want your, apple, coming out here and your trachea. You don't want to have that. Your Adam's apple. I couldn't remember that name. You don't want your Adam's apple getting enlarged like a male would have. You don't want that. You want to be feminine, but you want to have, libido, and you want to have energy. You want to have muscles and so on. But you don't want to be a man unless that's what you want. That's a whole different story. And so you want to watch the level. You don't want to have more than what's at the top of the reference range. So somewhere in the neighborhood of 50 would be usually tops. But like I said, there can be variations from different laboratories. So in summary, you don't want to overdose. You don't want to just automatically take or give testosterone to every woman based on any particular criteria related to menopause. You want to look at levels. You want to look at symptoms. And then it's a trial thing because we have no clear guidelines. We have no protocols. We have no indications for the use of testosterone in women that are FDA approved other than hypoactive sexual desire disorder. But it's totally fine and legal, and many doctors and many academics are recommending testosterone, but we don't have any products for women. We have to use compounded testosterone. Trying to use a man's product for a woman is almost always doomed to inaccuracies in terms of dosing. And pellets and shots are bad options, in my opinion. And the other thing I want to leave you with is if you go on testosterone and you're going into menopause and you do have low testosterone or other symptoms, first get the estrogen part of the hormone therapy right, because testosterone will lower estrogen receptor function. So it's harder to regulate your estrogen getting started if you start initially with testosterone at the same time. So do it layered. First get the estrogen component of hormone therapy right, and then add in the testosterone. Start low so we don't have side effects. Measure, monitor, and see how you feel. But know that just because you're going into menopause, that is absolutely not an indication to go on testosterone. It may even be a contraindication at that point to going on testosterone. Maybe it's best if you wait 5 years, but it's all individualized. That's the thing. You want to have individualized, personalized care because we're not all the same. So think about it and be cautious about starting testosterone. Don't jump in just because you've heard it's trendy.